So next we will transition to our Ask Me Anything. And we have Dr. Kaufman, Dr. Limke, Dr. Bain, and Dr. Coombs is also staying on for this. Sorry about that. Okay, wonderful. Glad you guys are all here. So families, if you have any questions, you can start throwing them into the chat. I do see one question that just popped up. What is the timeline for positive allosteric modulators as an available med that could be used in patients?
Yeah, this is very frustrating. I'm sorry. I'm not allowed to talk about the specific aspects in terms of the individual drugs. Um, yeah, I'm sorry. I can't really. Yeah, I can't. Yeah, I'm not allowed. I'm sorry.
That's totally fair. Looks like somebody was asking about dosage for L-serine. If anybody knows what was used in the trials.
I think the standard dose is 500 milligrams per kilogram per day. There is a certain variability in the literature for individuals that some got a little bit less, some got a little bit more, up to I think 800 or 850 or something was the highest dose that I am aware of. However, 500 is considered standard, and I think we don't really know what is the optimal dose because this hasn't really been looked into yet. So it could be that there's another dose that would be the ideal dose, but let's stick to 500 for the moment.
Sounds good. Okay, before we keep asking questions, I wanted to give our panelists the opportunity to introduce themselves quickly for those who might just be joining on and wanting to ask additional questions. We have a couple of new speakers that you haven't heard from earlier in the day, Dr. Limke and Dr. Bain, but everyone can feel free to introduce themselves, whoever wants to go first.
So I'm Jennifer Bain. I'm a child neurologist. I work at Columbia University in New York City. I previously given other talks to the community, so you might have seen me, but I didn't have the opportunity to meet everybody earlier. I care for individuals at Columbia University in New York City with several GRIN disorders, and I also help with some of those curation of the Simon Searchlight data that Dr. Chung had been speaking about before. So I'm happy to provide any of my experience as well as just general neurology recommendations, very similar to the work that Dr. Park does, and she presented earlier today.
Dr. Limke, if you want to introduce yourself. We had lots of registry questions earlier, so we're going to throw those your way too.
Okay. Yeah, so my name is Johannes Lemke. I'm a clinical geneticist working in Leipzig in Germany. And I do genetic, or in my lab, we do genetic diagnostics, and we counsel families on the impact. What does a GRIN diagnosis mean? And I have been doing research on GRIN-related disorders for more than 10 years now. And we also collect a lot of phenotypic data and host, together with Tim Benke in Colorado, we host the GRIN registry. And so we have a large collection of clinical data.
Amazing. Dr. Kaufman or Dr. Coombs, would you like to introduce yourself? Everybody's heard from you today, but if you want to, since people might have been on other sessions.
Sure. Keith Kaufman, movement disorders child neurologist at Mayo Clinic in Rochester, Minnesota.
Hi, Ian Coombs. I'm an electrophysiologist, so a researcher at University College London, and we specialise mostly in looking at AMP receptors, so the GRIA genes. But hopefully, I'll be able to answer around GRIN as well if required.
Wonderful. So we have some more questions being added in the chat. The next one, can splice variants be classified as either gain or loss, or are they automatically assumed to be one or the other?
I think that's a genetic question. I'll take that. We have to, there are two, but actually three different classes of variants. So they are the one are missense variants, and the other ones are null variants. Null variants comprise stop variants or frameshift variants or splice variants or truncating variants. There are several names. All these variants have in common that the gene copy is actually more or less destroyed and is not working properly. And the second gene copy is completely well and normal and healthy, let's say. And this is compared to missense variants, where both gene copies are working, but the one is normal and the other one is working abnormally and can lead to either a gain or a loss of function of the protein. And so that means missense variants can be loss or gain of function variants when looking at the protein function. And null variants are always, it's called, the official term is haploinsufficiency. They always lead to the destruction of one allele. They also have been called loss of function variants, but this relates to the loss of function of the allele, not the loss of function of the protein. That's why loss of function is a somewhat misleading term in this respect. But the question relates to splice variants are null variants, and this is not the type of loss of function variant that we are looking for when we are looking at GRIN variants. So this is a different class. However, null variants are somewhat similar in their outcome to missense loss of function variants. Yeah, but they're not gain of function. They are somewhat comparable to missense loss of function, but they're not the same as missense loss of function. I hope I didn't confuse people.
Thanks so much for your answer, Dr. Limke. So our next question is related to clinical trials. So for clinical trials, how distributed are the sites for patients who have trouble traveling? In the post-COVID era, are new models for participating in trials remotely being developed to help enrollment in rare disease trials? So whoever wants to take a stab at that.
So I don't think we have anybody on the call necessarily, like Dr. Panzara or Dr. Aguero, so we can't speak specifically. I would think that possibly the groups that are here today presenting to you are eager to find out where the patients are that would be eligible. So I would hope, and I would be positively optimistic that the groups that are looking to doing clinical trials are going to be thoughtful in where their choices are, so that they are making sure that they're in locations that they'll be able to find a lot of people, whether that's clinical centers of excellence or other clinicians and researchers and clinical trialist sites that have done clinical trials, but also have the availability of patients to potentially enroll. Part of the clinical trial process, I think Dr. Panzara talked about it earlier, is the companies will, or the sponsor would come to a specific site. For example, at Columbia, they come to me and say, would you be interested in looking into this clinical trial? Do you have the patients, or would you have the network of patients to enroll in this clinical trial? So I think I would be optimistic that because it's such a small community and because you have very targeted sponsors that are looking to do clinical trials, that they're going to be in locations that will be accessible. And we absolutely recognize in the world of rare disease that these are not single center locations. These are going to be multiple sites, because we recognize that it's not necessarily feasible for people to come with a rare disease to just one site.
Thanks, Dr. Bain. So our next question is related to, looks like diets, helping reduce seizures or behavioral abnormalities in kids with GRIA2 variants.
Yeah, not a clinician. I can only speak for the one patient that we've published. So it was a GRIA2 gain of function patient, and perampanel certainly seemed to help with seizures, but there was also a modified Atkins diet. So a ketogenic related diet also seemed to be helpful. I don't want to say any more than that. I'm sure the clinicians can maybe say a bit more about the ketogenic diet than me.
What I'll just add is that you heard a lot of different wonderful registry opportunities for people. I've spoken to the group before. You started with very small numbers in the registries, and it's been phenomenal to see your participation, and your numbers are much bigger. As you continue to provide your own feedback, your own experience with the diets and with these different medications, I think hopefully that it will become more and more clear to the researchers which diets seem to be clinically helpful, and then that gets brought back into the lab to further study that. So keep participating in registries.
Thank you both. So our next question is for Dr. Kaufman. What do you think of dexmedetomidine as a medication for PSH?
So dexmedetomidine, and the other follow-up question is there a non-IV form that can be used outside of the hospital? So dexmedetomidine is basically an IV clonidine. Okay, so clonidine is very similar in its chemistry to dexmedetomidine, which is why it worked well. So yeah, that's the answer.
Thank you. Okay, so our next question is related to GRIA2 with complex medical issues. And the question is related to the role of GRIA2 genes in causing complex medical issues such as intestinal failure, other neurological and neuromuscular issues.
Sorry, I didn't see the exact details of the question. Again, our one patient did have quite severe gastrointestinal. I think they had failure to thrive early in life. But then once the medications were sorted out and he was having less seizures, then lots of that seemed to be reversed. But yeah, I can't talk clinically about actually probably Dr. Bayat would be a better person to ask about this in terms of any trends that have been seen with GRIA2 and all these other varied symptoms.
Dr. Byde, I know you're on call, but if you want to take a stab at that in the chat, that would be fine too. Okay, so we'll transition to our next question. This one's for Dr. Coombs as well. Are there currently any GRIA animal models that are being studied? Is this important to have these types of models at this point?
Certainly, as you're developing new treatments and you want to start heading into clinical trials, having animal models is really, really important. And unfortunately for GRIA at the moment, we have basically none. We have the genetic knockouts, so the ones that completely lose their genes. And for our egos, they're not very good because they tend not to be nearly so sick as we kind of like them to be. Clearly, amphoreceptors are important, but if you completely remove them from a mouse, they're not normal, but they are not nearly so abnormal as you might think. In terms of patient variants, as far as I know, there's only been one GRIA3 variant that was incorporated into a mouse line. And yeah, again, the patients in question had enormously disrupted circadian rhythms. They were, I think, like one time they were awake for 106 hours and then slept for 48 hours. So it was kind of off the scale kind of things. And I think the mouse had a very, very slight change in activity at twilight. So at the moment, yeah, we don't have any models. Certainly for funding opportunities going forward, that's something that we are hoping to try and produce, to try and have something that would be of use to think about developing new treatments. But at the moment, we're not blessed.
Thank you, Dr. Kuhn. So our next question is related to the registries. So do you see a difference in symptoms, mild or severe, between patients carrying missense and truncation variants, specifically related to GRIN2B patients?
Yes, there is a difference. So if truncating variants belong to the group of null variants, and individuals with null variants in GRIN1, for example, they don't have any phenotype, they are healthy. If they have missense variants, they can be loss or gain of function and they are severely affected. If we look at GRIN2A, then we know for sure and have published that individuals with null variants are less severely affected than individuals with missense variants, no matter if gain or loss. However, gain are the most severe, loss are less severely affected, and null variants, carriers with null variants have a comparable severity as missense loss of function variants. And for GRIN2B, it's similar. We haven't yet statistically analyzed it, but the data show that individuals with null variants are less severely affected than individuals with missense variants.
Dr. Bain or Dr. Chung, anything you want to add from Simon's side, from what you guys have seen in your registry?
I'm not sure if so from our perspective, we haven't gone deep into the gain and loss of function yet. So what we are currently doing, thanks to the Simons Foundation, Dr. Lemke, Dr. Benke, myself, and Dr. Lau are trying to put all of that data together and see if we can get a larger data set and see whether or not the different variant does lead to different genotype-phenotype relationships.
Thank you. So we have another question related to genetics in the portal. We'll throw that at you, Dr. Lemke. So for variants in the portal that are listed as stop gain, what does that mean in terms of functional consequence?
That's also a null variant. Stop gain means that the gene has acquired an early stop. That means it's a truncation or a null variant, and yeah.
Thank you. So our next
So it
question.
doesn't have, it's not the gain may be misperceived as gain of function or something, but no, it's not a gain in this context. It's a stop that has been gained.
That makes sense. Dr. Coombs, so the next question is, it's a statement at the beginning. Clinical trials with AMPA PAMs have failed, at least in part due to dose-limiting toxicity. Are you measuring PAM affinities on the variants you record?
Yeah, the plan will be to do a full pharmacological analysis of these PAMs. So a lot of PAMs have been, there's a lot of safe PAMs out there because they've been through the early phase clinical trials and they've been shown to be safe. It's just that in the trials that taken them forward, they just haven't been effective against the indication that they've been raised against. Now, there's if none of these trials were for GRIA loss of function patients, let's put it that way, and so given that this is a precision therapy, there is a very good chance that they would be effective, and we know that they're safe. But the challenge is to get all the basic science in place to then try and take something forward, even if something has been in multiple clinical trials for depression or schizophrenia or obesity or whatever these drugs have been tried for before. There is still even if they failed in those, there's a better than even chance that they would be effective in the case of GRIA gain of function. So yeah, but of course we will be looking at the full effect of these PAMs on the variants to try and work out in what ways they can help rescue the response and hopefully try and normalize the response, and at what dose.
Thank you. So our next question will target to the clinicians. So could someone speak to brain-related changes in myelin due to GRI disorders? What experience do you have within patients with their MRI results?
I think abnormal myelination is not a classical typical feature of GRIN-related disorders. That doesn't mean that there are not this is not possible and to have or to see in a patient with a GRI-related disorder. But this is something unusual and uncommon, and it's not 100% clear whether this actually is a consequence of the GRI variant, or if there may be even an additional problem, perhaps a genetic problem, that contributed to this abnormal myelination. for answering this, it would be we would need to go into more detail and to look up the variant in detail, what variant has been detected in this child, and what is the exact phenotype to find out whether this fits together or not, and also actually check whether there's any other possible genetic explanation other than a GRI variant.
I'll tag on that. Well, I think the general consensus is that the GRI disorders affect the neurons and the connections between the neurons. Myelination is made by a different cell type in the central nervous system called the oligodendrocyte. So we don't think that that is as much involved or as much affected by the GRI genes. So that possibly is why. That being said, I'm not aware of a lot of people who are looking at studying the genetic effects of this on the other cell types. I'm sure it's important in one way or another, but at this point, given that we know that the gene is really critical for those connection of the cells between the neurons, we're not as much looking at the myelin-making cells, the oligodendrocytes. That being said, neurodevelopmental disorders as a whole very often have subtle changes in myelination, we use different terms like delayed myelination, abnormal myelination. It's not a primary issue. It might be a secondary and direct problem. And importantly, if you show different doctors the same MRI scan, they might read it a little bit differently. And so somebody might look at the same MRI and Dr. Kaufman and I might say that looks like a very healthy myelin pattern, whereas somebody else might not. And to my knowledge, I don't think anybody's really collected that information on a large number. So definitely the groups like Dr. Lemke and Dr. Benke and Dr. Bayat are collecting the MRI so that could be done as a piece of the data collection to say, as a large group, we're seeing these trends as a whole. So there might be subtle problems, but it's certainly not a large change in the group, and it's not completely surprising given the location of the problem.
Thank you both. So our next question is related to an increase in calprotectin in GRIN1 patients, if you've seen that and it reported in any patients. Nope. I'm pretty sure that's more related to like inflammatory bowel disease in terms of markers.
It's a protein that's a sign of intestinal inflammation. I'm not aware of any literature on it.
Right. I think that's definitely one thing in terms of better understanding the GI symptoms related to GRIN disorders. That's the reason why we are funding Dr. Dahlman's project. So we're excited to learn more about what's going on in the gut related to GRIN variants. So our next question is related to self-injurious behaviors. This person said, are there any models being studied to help reduce compulsion for self-injurious behaviors in the broader Greek community?
I'm not aware of any models, but from a neurodevelopmental disability standpoint, anytime I have a patient that has self-injurious behavior, the first thing I try to figure out is there an antecedent? Is there something that happens pretty consistently before the self-injurious behavior takes place that could be causing the self-injurious behavior to occur? And the other thing that I try to sort out is whether or not the self-injurious behavior is impulsive, meaning anytime there's an opportunity to do it, it happens, versus compulsive, where, no matter how much you try to eliminate the self-injurious behavior, it continues. So those are all the things from a neurodevelopment and neurobehavior standpoint I think about in trying to sort of unlock why it's happening.
I don't know any model systems, but I would say back to registries. I know for sure that the Simons registry and includes information about that. I do believe that Dr. Lemke and Dr. Benke's also includes some kind of behavioral data. So that's the kind of information that you'd need to present to both the researchers and then also the clinical trial. clinical trial group. For example, I believe Dr. Panzara put up a QR code for things that matter to the community. So that would be something that I would encourage you, if your child has experience and it has been a challenge, you need to let them know that, so that when they're doing the clinical trial, they're looking for that.
Certainly. Thank you both for that note. So our next question is related to truncation. Is there immediate nonsense-mediated mRNA decay preventing the production of defective proteins or subunits, or is there potential for continued translation resulting in the production of defective protein subunits?
That's a very genetic question. Yes, that's absolutely right. So if there's a truncation, a null variant, then the RNA is degraded and will not be processed toward translation of the protein. There are rare exceptions when the truncating variant is very, very distal in the gene. Then there may still be some gene product, but that's a very rare situation, and which usually does not apply. So normally a truncating or null variant will the copy of the gene copy carrying this null variant will not be translated.
Thank you, Dr. Lemke. So our next question is for Dr. Kaufman. Pediatricians do not treat PSH or even talk about it when they bring up the symptoms. The general response is that many things can cause that. What is your advice about how to go into the appointment and ask for treatment for PSH?
So my first thought would be ask to see a neurologist, because neurologists do know about autonomic dysfunction, and the autonomic dysfunction is actually a subboard of adult neurology. So most neurologists, adult and pediatric, know about disorders of autonomic function. In today's day and age, the other thing I tell patients and families is you have high resolution video typically at your disposal with either your phone or your iPad. Get videos of these events and show people these events so that they take the concern even more seriously if they see it. And then, yeah, neurologists are either adult or pediatric neurologists are the best people to assess this.
Thank you, Dr. Kaufman. We have another question for you. When gabapentin doesn't work so well or causes other symptoms, what else would be good to try alongside clonidine for PSH with dystonia?
It's a difficult / impossible question to answer without knowing the full story. Because I said in my talk earlier, there may be other medications that are being given that may be causing worsening of symptoms. And what I do whenever treatments that are typically recommended or thought about aren't working is I go through the other medications and ask if starting that medication or adjusting the dose of that medication may have contributed to changes in the frequency and severity of the PSH. So a good thorough med review of everything that's going on is always the first step before I jump to yet another agent.
Thank you. So I think we have currently made it through everything that's in the chat right now. So I'm going to go back to a couple of questions that we had from an earlier presentation. So this looks like it was from during Dr. Park's talk. It's more clinically oriented, so I'll direct it your way, Dr. Bain or Dr. Kaufman. So this is related to seizure medications. They said that the heavy hitter medications like Depakote had raised ammonia levels. Keto has failed. They're not a candidate for surgery. They're averaging 8 to 12 seizures monthly and have failed 8 medications. They said, what other options do they have? So in general, I guess speaking broadly about seizure medications.
So I will highlight Dr. Park's disclaimer page, which included her disclosures for for sponsors and pharmaceutical and funding, but it also said this is not a clinical presentation. Please discuss this with your specific clinician. So please do always discuss this with your clinicians. I am not an epileptologist by training. My colleague who you heard earlier, Dr. Tristan Sands, is. I do think that some comments that I can make similar to hers is that as you fail one medication, you are at a less likelihood of having the ability to gain full seizure control. So you add one, you're less likely. You add two, it's less likely. You add three, you're less likely. So that's just something to be aware of. There are some precision medicine theories and precision medicine interventions that are out there. And I think that's exactly the point of this. Dr. Bayat can actually go through and say what exactly should be the correct dose of perampanel given this, the function of or dysfunction of this variant. That being said, working with a neurologist that has the expertise in epilepsy management, if it gets to the point where you are on 4, 5, 6 different medications, it's not unreasonable to think about seeing an epilepsy specialist, for example, and considering something that might involve more discussion and further discussion. But certainly, I think as you've continued down the line in your journey, there's not going to be one simple answer. And I think clearly from the data that even Dr. Chung presented from the Simon Searchlight data, you could see that what they showed was really anything. And so there's not one medication that seems to be addressing all the needs here. Importantly, the role of genetic testing and when that genetic test comes in is very likely later in many cases than when the epilepsy started or when the seizures started. So if they started with seizures, Dr. Sands made a lovely comment in the commentary. So he's welcome to pop on after this. But I would say, if they were diagnosed with epilepsy first and then GRIN was added to their diagnosis, they might have already been through many medications that were based on epilepsy, not necessarily on the GRIN disorder, as opposed to some who might have started with the genetic diagnosis and they had more targeted therapy. And I think all those answers will continue to come out as longitudinal registries give us information about when the seizures come out, what are the medications that seem to be working, and are there particular ones at certain times that might be helpful. I don't know if Dr. Sands has the ability to say something, but I see him typing feverishly.
Thank you so much for your input, Dr. Bain and Dr. Sands. I don't know if one of our Zoom techs can unmute Dr. Sands if you want to say something. Yes, there you go.
Hi, can you hear and see me? Okay, good. Yeah, even when we add and this has been, I think, clear across the talks today, even when you add the dimension of the genotype to a patient's epilepsy history, the types of seizures they have, what types of side effects they might be particularly susceptible to. All the patients, even patients with the exact same variant, are individuals. And I think the challenge with epilepsy care and epilepsy management is that it actually really needs to be tailored to the individual. I mean, that it's sort of like a different type of precision medicine in a way, because it's really focused on that particular individual and how they're responding. Level 4 epilepsy centers are designated centers that provide a spectrum of services, including things like ketogenic diet, epilepsy surgery, importantly. And more and more, the expectation is now also that they have genetic testing, which is very relevant to the group here. And so I think you want to be seen by somebody at one of those centers who's willing to think very carefully about the child as an individual and try to sculpt. At the end of the day, seizures are a symptom, and the treatment has to be sort of, it has to balance the side effects with the treatment, and I think that can be challenging. Yeah, I think I'm repeating myself. So
thank you so much for your input, Dr. Sands. Okay, so we have a beast of a question next. Given the intricate network of ionotropic glutamate receptors such as NMDA, AMPA, kainate, and metabotropic glutamate receptors, as well as GLUD receptors, interaction with GABAergic signaling, how to determine which channels are most relevant to investigate for therapeutic targets in a GRI patient? Is the clinical signs on each patient that could determine this? Maybe look at a bigger rare patient group and their target therapy, since GRIN patients with the same mutation can have different clinical signs. So if you guys want to take a look and read that in the chat as well, and maybe parse through what you think might be an answer on how to approach that. I guess they're trying to get at would it be helpful to also connect with other rare patient groups for some of these other indications as well?
Yeah, I guess, I talked about precision therapies, and in terms of precision therapies, you're really focusing, even though all these proteins work together and they're all part of a system, you don't have to go too far away from the exact protein before it's just any old therapy. There are, targeting AMPA receptors when they're defective is obviously quite effective. Potentially targeting NMDA receptors, because AMPA receptors and NMDA receptors are, in the same place. That is also worthwhile doing. But by the time a neuron has received the glutamate signal and then passed it on a little bit, then pretty much anything that modulates neuronal signaling can then potentially help. So while precision therapies are obviously a very good thing to be going for, you don't have to get too far away before there's kind of no point kind of trying to think of them as kind of related. So I think looking at drugs that affect other types of glutamate receptors, if you have a GRI disorder, is kind of worthwhile. But that doesn't mean that looking at GABA drugs or any other drugs should be excluded. I'm not sure I answered that particularly well. Take it away, anyone else?
Thanks for your input, Dr. Coombs. Okay, we have another question in the chat, and we will be coming up on, looks like, our Patient Impact Awards and closing remarks session. So we'll end off with this one. So this person describes that at different ages, their son's seizures changed, getting less often as he grew older, and had to change seizure meds. Do seizures have seasons or often change with age?
Seizures can definitely change with age, or frequency can change, and also seizure types can change. We know that for GRIN2A null variant carriers, seizures usually start at plus minus preschool age and will end in early puberty, plus minus, whereas GRIN2A gain of function missense carriers, they can have epilepsy onset neonatally, and they do not have a particular offset of seizures. So it really depends on the variant and on the gene when seizures start and if they stop, and how they may change over time. But there is a possibility of change.
Thank you so much to our panelists. If we don't have anything else, it looks like we're getting some very specific, child-specific questions in the chat. So I'll pass things over to Keith for our Patient Impact Awards, but I want to thank our panelists, all of our speakers. Thank you so much, Dr. Kaufman, Dr. Lemke, Dr. Coombs, and Dr. Bain, as well as Dr. Sands, for all of your input and trying to address as many questions as we could in a rapid fire session. So I'll turn things over to Keith to close us out.